Hello, I'm William Taylor. I'm a neurosurgeon at the University of California, San Diego. I've been there for almost 25 years. I'm a professor of neurosurgery and one of the founders of the Society for Minimally Invasive Spine Surgery. This is a short, hot topic in spine surgery, and what I'd like to talk to you about today is a prone trans-psoas approach. As you know, the lateral lumbar interbody fusion was popularized in the last 10 to 15 years, but it has only really come into about 20% of the population of surgeons using it. And there's certainly various reasons for that. It may be neurologic injury, it may be difficulty positioning, it may be not wanting to learn a new procedure, or time consuming. And what we've done is change the lateral procedure around. And in fact, we've really reimagined and reevaluated the entire lateral procedure from the beginning to end, and we call that the prone trans-psoas now. The prone trans-psoas is dedicated to doing surgery with the patient in the prone position. The positioning offers a lot of advantages over the lateral position. First, I would say it offers the chance to position the patient very easily, simply, and quickly. Secondly, the position in the prone surgery allows you not to have to flip the patient or move them during surgery. So you're saving a significant amount of time already. And we all know how important lordosis is, and the positioning of the patient prone allows you to have lordosis. The positioning, though, in the prone trans-psoas is something that needs to be done carefully, and we use a patient positioner. It's supplied by a company. And what this does is lock the patient to the bed. One of the problems with the prone trans-psoas is that the patient tends to move when you push them or operate at the time of surgery. And so it's imperative that you lock the patient to the bed. It's imperative then that you have equipment that then locks the bed to the retractor and the retractor to the patient. So reimagining that, we've reimagined the retractor, reevaluated it to build a solid two-blade, light retractor that's held firmly from the top so that it doesn't tend to fall down, which what happens if you use some older, heavier, three-bladed retractors. And those are really designed for the person in the lateral procedure, in the lateral position. So a new retractor, and then also we've reimagined and reevaluated the docking and the approach to the retroperitoneal access. The retroperitoneal access is made much easier with the person in the prone position. You can open up the space quite easily. The incision tends to be a little bit smaller. The working distance is a little bit longer, and that's why it's imperative to use good navigation, or to use excellent fluoro, or to use an appropriate rigid retractor. And so when we do that, then we position the patient prone. We access the retroperitoneal space by going near the quadratus or posteriorly at the transverse process. And then access the mid portion of the disc. But really what we're doing with neuromonitoring is we're accessing the safe working channel. And then a two-bladed retractor then allows you to either move the retractor posterior or anterior depending on where you've docked in the mid portion of the disc. So safe disc space, two-bladed retractor, and then opening either anterior or posterior. And that also can be changed around if you want to go more posterior for more indirect decompression, or anterior for more lordosis. So then after we get down the retroperitoneal access, the next step really is to monitor the patient during the surgery. And an integrated somatosensory evoked potential using a saphenous SSEP is absolutely critical for this prone procedure and also for any lateral procedure. It can be done with standard Cadwell monitoring by the neurophysiologist, but much more safely and efficiently done by a dedicated system, such as SafeOp or one of the other systems that monitor SSEPs. So we're monitoring, we get real-time information, which allows us to do multiple procedures. We've gained retroperitoneal access, which is easier. We have implants which are specifically designed to put in that position. And I think we've simplified the procedure, we've made it safer for patients, and then we're in the process of documenting that. The last thing I would say, and I think the two most important reasons are that we now all of a sudden have made single position surgery with navigation or robotics much easier to do. The navigation and robotic piece is critical as we move forward, as more and more and more people are using robotics and navigation. And operating in the prone position rather than lateral position is absolutely critical for that. The second thing you do in the prone position is you simplify your decision making. You no longer have to concern yourself about indirect decompression or lateral fixation. You really can do exactly what you would normally do with your patients. And if you prefer to do a decompression, you can do a decompression and take advantage of the large cage. You can rely on indirect decompression. And I think you've simplified your decision making and approach to the patients. So I find the prone trans-psoas approach to be absolutely a new and a different way to do a lateral procedure. I think it's going to prove to be better, and we're just in the early stages of gathering data and making sure that this procedure is safe. Thank you very much for listening to my shots video, and I hope you'll try the prone trans-psoas procedure with us. Thank you.